In our previous adventure, we went back in time to 1912, the night the unsinkable Titanic sank, to explore the clinical presentation of hypertension. In this sketch, we'll be talking about how we actually take care of these patients. Like these modern day divers investigating every nook and cranny of the Titanic's remains, we'll leave no stone unturned and no safe uncracked. Bonus points for anyone who finds that pesky diamond Bill Paxton was looking for. Let's begin with a recap of the presentation of primary hypertension from our last sketch. Wallace Hartley is a 54-year-old man who presents to establish care. He has no complaints, no significant past medical history, and does not take any medications. Family history is significant only for hypertension on his mother's side. Vital signs are significant for a blood pressure of 154 over 92 and a BMI of 28. His physical exam is otherwise unremarkable. Routine labs, including BMP, creatinine, calcium, TSH, and fasting lipid profile, are unremarkable. His ECG is significant for left ventricular hypertrophy. Based on these findings and his initial workup, Mr. Hartley most likely has chronic stage 2 primary hypertension. We'll be focusing our attention on the management of primary hypertension in this video, since it accounts for 95% of all cases of hypertension. Primary hypertension might be a common problem, but managing it properly is no small feat. Nearly half of patients with high blood pressure are not adequately controlled. Why do we even need to treat hypertension anyway? Well, as you're probably aware, hypertension is associated with bad cardiovascular complications, like coronary artery disease, myocardial infarction, heart failure, stroke, aneurysms, and end organ damage like retinopathy and nephropathy. Controlling hypertension is one of the most important things you can do to reduce the risk of cardiovascular disease. In fact, every 20-point increase in systolic blood pressure doubles the risk of death from stroke and ischemic heart disease. That's why we've drawn in two risky-looking anglerfish at the bottom of this depth marker with 20-millimeter increments. Anywho, the first order of business in the management of patients with hypertension is to understand their other risk factors for cardiovascular disease. That's because patients at higher risk are treated more aggressively. This is where your history and physical really comes in handy because it is directly related to how you're going to manage your patient. So, with that in mind, let's quickly run through the risk factors that will affect your management. For all the details on the clinical presentation of hypertension, head back over to part 1 of this series. Certain patient characteristics increase the risk for cardiovascular complications. Remember our sleepy captain who is male, African American, older, and obese? All of these characteristics not only are independent risk factors for primary hypertension, they also increase the risk of cardiovascular complications. Comorbid conditions, specifically diabetes and hyperlipidemia, are also important risk factors for cardiovascular complications. In addition to assessing for risk factors, it's also important to take existing cardiovascular disease into account when you assess your patient's cardiovascular risk. That means looking for things like hypertensive retinopathy, heart failure, left ventricular hypertrophy, prior MI, and chronic kidney disease. Okay, divers, let's descend into the magical underwater world of hypertension management and discover what else we can do to keep these patients as healthy as possible. First things first. The 2017 guidelines from the ACC and AHA recommend a target blood pressure of below 130 over 80 millimeters of mercury. That said, it is reasonable to consider less strict control for elderly patients with many comorbidities, particularly if they have a limited life expectancy, which is why this elderly submarine passenger wants to ascend a bit more. We begin treatment with lifestyle modification interventions. These are prescribed to all patients with elevated blood pressure. Our chubby diver illustrates some of the ways we can lower blood pressure even without medications. Moderate aerobic exercise for 30 minutes 5 times a week, represented by the diver's rhythmic swimming, can have a dramatic impact on blood pressure independent of weight loss. Speaking of which, weight loss itself is also significantly beneficial. That's why we've drawn in this weight belt starting to loosen up and fall off the not-so-chubby diver. In fact, in overweight or obese patients, weight loss is the most effective non-pharmacologic treatment for lowering blood pressure. Next, the DASH diet, which stands for Dietary Approaches to Stop Hypertension, is also proven to reduce high blood pressure. The DASH diet consists mostly of fresh fruits and vegetables, whole grains, and low-fat dairy products. After weight loss, the DASH diet is the most effective non pharmacologic treatment for hypertension, especially in non obese patients. A diet rich in potassium and low in sodium can help reduce blood pressure as well, independent of what's already in the DASH diet. Changing recreational habits, like reducing alcohol use, quitting smoking, and cutting down on caffeine, can also help blood pressure control. Lastly, if a patient is on a medication that's known to increase blood pressure, like a nasal decongestant, try to reduce its use and ultimately discontinue if possible. Lifestyle modification is definitely the unsung hero of hypertension management. Make sure you emphasize it every time you see your patient with high blood pressure. Still, despite your and the patient's best efforts, eventually you'll need to prescribe some medications. Let's take a look at the common pharmacotherapies for hypertension that you'll need to know. Remember, the reason we treat hypertension is to prevent cardiovascular complications. The risk of these bad sequelae depends on which stage of hypertension your patient is in. Remember those from our last sketch? Let's start by talking about patients with stage 1 hypertension, which, as you may recall, is defined as a systolic blood pressure between 130 and 139, or a diastolic blood pressure between 80 and 89. According to the 2017 ACC/AHA guidelines, antihypertensive medication is recommended for patients with stage 1 hypertension and a high risk of developing atherosclerotic cardiovascular events. How is high risk defined? Glad you asked. Patients with existing cardiovascular disease, such as a history of MI, angina, peripheral arterial disease, TIA, or stroke, definitely fall into the high risk category. In addition, we also include patients with an estimated 10-year atherosclerotic cardiovascular disease risk of at least 10%. That's why this sign says for ASCVD 10 or higher. Notice how it's posted on a nasty, gunky red pipe? Don't worry. The ACC/AHA has a handy dandy ASCVD 10-year risk calculator that does all the legwork for you. It takes into account a whole host of factors, like age, race, history of diabetes, cholesterol, HDL, and tobacco use. By contrast, patients with stage 1 hypertension and a low risk of cardiovascular events only require lifestyle modifications, which is why this low risk sign is pointing up to that chubby diver. For patients with stage 1 hypertension, we have several options for initial therapy. The ACC/AHA guidelines recommend starting pharmacotherapy with one of the first line antihypertensive drugs. These include a long acting calcium channel blocker, represented by this broken calcium soft serve machine, a thiazide diuretic, an angiotensin converting enzyme inhibitor, or an angiotensin 2 receptor blocker. Let's take a closer look at each of these first line classes of medications, starting with thiazide diuretics. Thiazide type diuretics, such as chlorthalidone and hydrochlorothiazide, are represented by this diverse white chlorothies. We mentioned chlorthalidone first because it's actually the preferred thiazide type diuretic to use in hypertension. It's been proven to reduce the risk of cardiovascular complications and has a longer duration of action than hydrochlorothiazide. However, thiazides are notorious for causing a slew of adverse effects, represented by this treasure chest of complications. The most common electrolyte derangements caused by thiazides include hypokalemia, hyponatremia, hypomagnesemia, and hypercalcemia. But that's not all. Thiazides can also cause metabolic side effects, such as hyperglycemia, represented by this floating jar of candy, hyperlipidemia, by this delicious fatty stick of butter, and hyperuricemia, represented by this floating knitting needle with yarn. Moving on. ACE inhibitors and ARBs are also great first-line options for primary hypertension. If you remember way back to physiology and the renin-angiotensin-aldosterone system, ACE converts angiotensin 1 to angiotensin 2. Blocking this system with an ACE inhibitor or an ARB decreases angiotensin 2 and aldosterone, which lowers blood pressure by decreasing vasoconstriction and promoting natriuresis. Between the two, ACE inhibitors are typically tried first, but ARBs can be used if patients don't tolerate ACE inhibitors. Why wouldn't patients tolerate ACE inhibitors? Well, for starters, ACE inhibitors can make some patients cough a lot. ACE participates in the degradation of bradykinin, which means ACE inhibitors can cause bradykinin to accumulate in the lungs, leading to a dry cough in up to 10% of patients who take them. To help you remember that increased bradykinin is responsible for the ACE inhibitor associated cough, We've drawn in this coughing Titanic victim with braids in her hair. Not sure why she still has hair. Seawater does a body good. Anywho, since ARBs don't interfere with the action of ACE, they don't cause this side effect. That's why you should switch your patient over to an ARB if they complain of cough on ACE inhibitors. Side effects common to both ACE inhibitors and ARBs include hyperkalemia, represented by this tasty banana daiquiri, and angioedema, represented by the fish with swollen red lips. Another and, quote, adverse effect of ACE inhibitors and ARBs is a decline in GFR with rise in creatinine. We don't symbolize it here because it's less of a side effect and more of an expected response. In fact, reducing glomerular pressure, and thus GFR, is one of the therapeutic effects of ACE inhibitors and ARBs. That being said, it is commonly listed as an adverse effect and is something to take into account when prescribing these medications. Last but not least, we've got calcium channel blockers. Let's start with amlodipine, represented by the Dippin's topping station with marshmallow sauce. Amlodipine is a long-acting dihydropyridine calcium channel blocker, and it's the most common calcium channel blocker prescribed for hypertension. The main side effect is peripheral lower extremity edema, represented by this poor sailor with swollen pant legs. Other calcium channel blockers include non-dihydropyridines, such as verapamil and diltiazem, but these are less commonly used for high blood pressure. Instead, we often use them for rhythm control. Check out our chapter on arrhythmias for all the deets and beats. In a patient with high blood pressure and no other comorbidities, these medication classes are generally equally effective. However, it's hard to predict a specific patient's individual response. So, if your patient's blood pressure is not at goal after initiating monotherapy, the best option is to switch to a different medication class. Variability between patients means there's a good chance your patient may respond better to another drug class if one isn't working out. You can also increase the dose of monotherapy. But increasing the dose typically only marginally improves blood pressure control while increasing the incidence of adverse effects. Finally, if your patient's blood pressure still isn't at goal after these tweaks, move on to combination therapy. More on this in a second. Ready to dive deeper? Let's talk about the management of stage 2 hypertension. All patients with stage 2 hypertension, defined as a systolic blood pressure of 140 or higher, or a diastolic blood pressure of 90 or higher, require pharmacotherapy in addition to lifestyle modifications. Hence the glut of pill bottles surrounding this deeper diver. In fact, many patients with stage 2 hypertension require multiple medications for adequate control. Specifically, if your patient's initial blood pressures are way above goal, like systolics more than 20 points or diastolics more than 10 points above goal, start combination therapy with 2 drugs right out of the gate. In light of the 130/80 goal, this means starting combination therapy at a systolic blood pressure of 150 or diastolic blood pressure of 90. The recommended combination is to start an ACE inhibitor or ARB plus a long-acting calcium channel blocker like amlodipine. Once again, higher doses don't reduce blood pressures that much more than lower doses, but they do increase the rate of adverse effects. That means you actually achieve better blood pressure control with multiple drugs at lower doses than a single drug at its maximum dose. If combination therapy doesn't bring your patient's blood pressure under control, you've got 2 options. Either increase the dosing of the 2 drugs, represented by these 2 larger pill bottles, or add a third agent, represented by these 3 regular sized pill bottles. These are the general recommendations for treatment of hypertension. Certain groups of patients, however, will benefit from different medication regimens that are tailored to their individual characteristics or comorbid diseases. For Black patients with primary hypertension, a long-acting dihydropyridine calcium channel blocker like amlodipine or a thiazide diuretic is recommended for initial monotherapy. ACE inhibitors and ARBs are less effective as monotherapy in Black patients. But if blood pressures are still above goal after initiating therapy, an ACE inhibitor or ARB is the recommended second agent. Speaking of which, ACE inhibitors and ARBs are highly recommended in patients with hypertension and proteinuric chronic kidney disease, represented by our recurring kidney pulleys surrounded in a cloud of murky protein water. You definitely want these on board since they can slow the progression of kidney disease. Similarly, there's very clear evidence that ACE inhibitors and ARBs are beneficial in hypertensive patients with diabetes and severe albuminuria since they can slow the progression of diabetic nephropathy. Because of this, an ACE inhibitor or ARB should be the first antihypertensive drug you start in a diabetic patient. A frequent subset of patients you'll encounter have both hypertension and heart failure with reduced ejection fraction, aka HFrEF. This is represented by our recurring sketchy symbol, the floppy heart balloon. Nearby, you can see the sign from the Angel of New Orleans, which somehow ended up drifting all the way out to sea. ACE inhibitors and ARBs, represented by the cracked Ace of Spades card, and beta blockers, represented by the Jack's muted beta bugle, are the recommended agents in hypertensive patients with HFrEF. This is super convenient since these are the drugs that are also the recommended first line agents for straight up HFrEF. Both these drugs are especially useful in patients with HFrEF and a history of acute coronary syndrome, as they've been shown to significantly reduce mortality in these patients. That's why this last card in the deck is an angel, our recurring sketchy symbol for mortality reduction. She's playing a heart shaped harp with a broken string, our recurring symbol for ACS. Likewise, aldosterone receptor antagonists, such as spironolactone and eplerenone, which are recommended for certain heart failure patients, can also help with blood pressure reduction. For more details on the management of chronic heart failure, check out our sketch dedicated to it in the heart failure chapter. Remember the orchestra that bravely played on while the Titanic sank? Let's honor them by moving down to the old music room to talk about beta blockers. Beta blockers are not recommended as first line monotherapy for hypertension, but they can be used in hypertensive patients who also have one of several other conditions. These include atrial fibrillation, angina, essential tremor, and as prophylaxis for migraines. Side effects of beta blockers include bronchoconstriction, shown here by the skeleton blowing a long, loud party blower, and bradycardia, illustrated by this broken heart shaped pocket watch. If there's a beta, there must be an alpha, right? Well, alpha blockers like prazosin, represented by this blown out alpha candle wick, aren't recommended as initial therapy for hypertension, but they can be helpful for hypertensive patients with another reason for using it, like men with benign prostatic hyperplasia. Loop diuretics, like furosemide and bumetanide, are typically used to treat volume overload symptoms caused by heart failure or chronic kidney disease, but they also provide some antihypertensive benefits. Don't use them as monotherapy for hypertension, but let this bloated diver's loop of tubing help you keep that BP lowering effect in mind when you're using loop diuretics for fluid removal. Side effects to watch for with loop diuretics include ototoxicity, hence why this diver's head is rattling from the loud gong, hypokalemia, and metabolic alkalosis, represented by this basic bar of soap. Despite all the drugs we have at our disposal, some patients' blood pressures just won't get under control. Ugh, I give up. If your patient is still hypertensive despite a regimen of 3 or more drugs, one of which has to be a diuretic, they're said to have resistant hypertension. As we explained in our previous sketch on the clinical presentation of hypertension, a patient with resistant hypertension should raise red flags for secondary hypertension. But before you kick off an expensive and meticulous workup, make sure your patient is actually taking their medications. Poor adherence to medications is a common cause of seemingly resistant hypertension. After that, confirm your patient is actually on an appropriate treatment regimen. Ideally, they should be on all 3 of the preferred first line therapies: a long acting calcium channel blocker, thiazide diuretic, an ACE inhibitor, or ARB. If not, make it so. Once you've made sure that your patient's resistant hypertension is real, it's time to explore other, less common treatment options, which we'll find on the other side of that pesky resistant door. At the same time, you should also work up your patient for causes of secondary hypertension, such as renal artery stenosis, renal parenchymal disease, primary aldosteronism, Cushing syndrome, pheochromocytoma, hyper or hypothyroidism, hyperparathyroidism, and coarctation of the aorta. If you haven't already, check out part 1 of this series on hypertension for more details on the etiology and workup of secondary hypertension. When it comes to the management of resistant hypertension, aldosterone receptor antagonists, represented by this fallen mineral crystal chandelier, such as spironolactone or eplerenone, are often effective. Both spironolactone and eplerenone can cause hyperkalemia, so potassium levels need to be monitored in patients taking these drugs. Spironolactone, in particular, illustrated by the spiral notebook on the table, can also cause gynecomastia, represented by these familiar looking round food dishes, as well as erectile dysfunction, particularly at higher doses. Fortunately, eplerenone does not cause these side effects. If your patient's blood pressure is still not at goal, additional drugs that can be added to treat resistant hypertension include beta blockers, particularly vasodilators like labetalol, carvedilol, and bisoprolol, direct vasodilators like hydralazine and minoxidil, represented by this red shirt with the super baggy sleeves, or the centrally acting alpha 2 agonist clonidine, represented by this bear rug with its giant bear claws. If you find yourself navigating the dangerous waters of resistant hypertension alone, call for help. These patients warrant referral to a hypertension expert, like a cardiologist or nephrologist. Not saying you aren't one, but, yeah. Alright, let's wrap up this sketch with a brief review of what we've learned. In most patients, your goal should be a blood pressure below 130 over 80. To get there, we have two major categories of interventions at our disposal: lifestyle modification and pharmacotherapy. Lifestyle modification, which should be encouraged in all patients with elevated blood pressure, include aerobic exercise, weight loss, the DASH diet, potassium supplementation, sodium limitation, and moderation of alcohol use. When patients have stage 1 hypertension, which is defined as systolics of 130 to 139 or diastolics of 80 to 89, pharmacotherapy should be added to a lifestyle modification regimen only in patients who are at high risk of atherosclerotic cardiovascular disease. Once you've determined that your patient warrants pharmacotherapy, the starting point for most patients should be one of the big three: thiazide diuretics, such as chlorthalidone, ACE inhibitors, like lisinopril, or ARBs, like losartan, or long-acting calcium channel blockers, like amlodipine. If you go with a thiazide, be aware that they may cause a variety of electrolyte and metabolic side effects, such as hypokalemia, hyponatremia, hypomagnesemia, hyperglycemia, hyperlipidemia, and hyperuricemia. If you go the ACE inhibitor route, watch out for cough, hyperkalemia, and angioedema. Switch your patient over to an ARB if they complain of coughing, but be aware that hyperkalemia and angioedema can occur with ARBs as well. Finally, with amlodipine, the major side effect to watch out for is lower extremity edema. While these three drug classes are generally equally effective at treating primary hypertension, there are a few specific cases in which you'd prefer one particular class over another. For instance, thiazides and calcium channel blockers are preferred for initial monotherapy in Black patients, whereas ACE inhibitors or ARBs are preferred for patients with proteinuric chronic kidney disease or diabetes. If your stage 1 hypertension patient's blood pressure isn't at goal using one of these drug classes, the correct play is to switch to a different drug class. This maximizes the likelihood that you can get that blood pressure under control while minimizing the risk of adverse effects. By the time patients are in stage 2 hypertension, defined as systolics of 140 or higher, or diastolics of 90 or higher, everyone requires pharmacotherapy. In fact, many patients with stage 2 hypertension actually require combination pharmacotherapy with two different classes of drugs, most commonly an ACE inhibitor or ARB plus a calcium channel blocker. If patients on combination therapy still aren't at their blood pressure goal, you've got two options: increase the dose of the two agents, or add a third drug class. Speaking of other drug classes, there are quite a few beyond the big three that are also used, albeit typically in patients with other comorbidities. For instance, beta blockers are recommended in hypertensive patients with heart failure and reduced ejection fraction, in addition to an ACE inhibitor or ARB. Beta blockers are also good for hypertensive patients with AFib, CAD, essential tremor, or migraine, since they're often used to treat these conditions anyway. Meanwhile, alpha blockers, such as prazosin, can be a good choice for hypertensive men who also have BPH. Loop diuretics like furosemide and bumetanide have some antihypertensive effects, but they're typically only used for volume overload symptoms in patients with heart failure or advanced kidney disease. Alright, so you've got your patient on three different classes of meds and they're still not at goal. You might just have resistant hypertension on your hands. However, before you go ahead and start prescribing exotic antihypertensives, make sure your patient is on an appropriate regimen of drugs and that they're compliant in taking them. These are by far the most common reasons for apparently resistant hypertension. Once you've confirmed that resistant hypertension is real, then start your workup for the common causes of secondary hypertension, which we covered in part 1 of this series. While you're at it, consider adding some of these less common antihypertensives to your patient's regimen, including aldosterone receptor antagonists like spironolactone and eplerenone, beta blockers, direct acting vasodilators like hydralazine, or the centrally acting alpha 2 agonist clonidine. By the time you get to these options, however, you should probably call a hypertension specialist for help. All right, we've scoured every inch of this wreckage site and gotten you up to snuff on hypertension management. In our third and final part of this series, we'll tackle a super scary